It's for me in the chat that has a concern. Are they just sending it? Too STD for that though. All right. Not that loud. Must be like.
Yeah.
I'll try. That's fine. Hello. That's fine. That's fine. All right. Good afternoon. That was implied in my loud all right. Hello. How's everybody? Happy whatever day of the week it is. Wednesday? Hump day. All right, cool. So this is Research Methods 5. As y'all, for those of you who actually check your conference schedule, this is Research Methods / Public Health, but the stuff I wanted to cover took longer than I expected. So we will jump back and forth to some public health topics. I have tried to integrate some into this, but with relative success. But next month, it is going to be a guest lecture by Dr. Greg Heath, who some of y'all who've been around for a minute might know of him. He used to do a lot of the like statistics liaison stuff with UTC. He is an epidemiologist by trade. He was with the CDC for several years. He's actually worked on a lot of really cool stuff. So he's going to come and do some public health topics in this slot next month. And then I'm going to truck through. I think I probably can get through everything I want to in a couple more lectures. And then I'll plan on doing it kind of on a cycle because this is just the type of stuff you have to hear over and over again. But that's sort of the plan. Sound good? Yes. Okay. Other sort of general plug, y'all. Did y'all get the email about using the care coordinator? Okay. Does the flow for that make sense? Okay, so this should become part of your practice habit. So every time you're discharging a patient, particularly if you know like a day or so in advance, confirm with the patient who their PCP is and just message Andrea. She will make the appointment for you. She will put it in the discharge section. Even if the patient's not established with a PCP, ask them who they want to see. She can make that appointment. She just needs to know who it's with and ideally when you'd like them to be seen. She also can do specialist appointments. If they're established with the specialist, the process is exactly the same as for the PCP. If they're not, you just need to go ahead and sign an ambulatory referral because the office will need the referral to make the appointment, but she can go ahead and make those appointments as well. So it's a really good way to improve sort of continuity of care for our patients and sort of improve the, hopefully, rates of bounce back and that people can be successful when they leave the hospital.
So no more like sending a staff message over the dots, and if we send them over there and they don't already have someone, she'll take care of that.
Yes. So it's always, always, always better for the patient to have an actual appointment time. So, if in my experience, the messaging Dotson has a kind of a hit or miss effect. So certainly make sure they're seen by the right people and tell Andrea if it's one of yours or one of somebody that's established, estimate when that person's going to be in clinic or say at the next time that person is in clinic. But the idea is that she can do some of that alleviate some of that administrative burden for y'all. And, for med students and things like that, which, y'all are great about helping us do stuff like that. But I think there's more educational things y'all could be doing. So she's a great resource. We need to use her so that she doesn't go away. And it took a while to kind of get them to be agreeable to y'all using her. So use her for sure. Yeah.
We also use that in the outpatient setting. Specialist for what's established with them. So when I send her a message, or do I just contact her directly since it's not too strict?
Technically for now, it's inpatient. We're going to explore what it does to her volume with us using her routinely. And then if she has bandwidth, she's super game for whatever, but we want to make sure that we're still kind of having her operate within her current bandwidth, which was originally just to serve like the hospital side, but she's able to do both. So we're going to do a trial of that, but I'll keep that kind of in the future directions category. Cool. Okay, we're going to dive in. So as usual, we're going to do a recap of some of the things we talked about so far. So just in broad strokes, we've talked a lot about study design. We've talked about essentially types of study designs, but also the components of a good study design, the components of a good research question, how to operationalize variables. And then we've talked a little bit about what is essentially sort of descriptive statistics. So how do you describe how much disease is out there and what does that mean? So we're going to recap some of that in our kind of classic Q&A format, and then we're going to get into relative measures of association. So this time we're going to do relative measures of association. Next time we're going to do absolute measures of association. We'll talk about, don't panic if you don't know what that means. Next time we'll talk about absolute measures of association, and then we'll get into test statistics. So things like using a t-test and using a chi-squared, and when are those things useful? And the goal of this, and I am going to go through the math, but that's more for people who learn by seeing it done, and less for the fact that I expect you to be able to do the math. Because the whole goal of this is not necessarily that you can be your own statistician. That's really beyond the scope of this, but so that you understand what you're looking at, and also so you can recognize when things don't look right. Because a lot of times there's a gap between the statistician's knowledge of the medical issue and your knowledge of the statistics. So if you can come a little bit closer to them on your understanding of the statistics, you can pick out stuff that may not be adding up, particularly in your own projects, and then also when you're kind of critically reviewing the literature. All right, Dr. Kremser. Blank has occurred when a systematic error is introduced into sampling or testing by selecting or encouraging one outcome or answer over another. Very good. Yeah, so big things there, remembering that bias is not how it's used colloquially. It's not like you're real mean to another person. It's a systematic thing. It can happen in the sampling portion. It can happen in the testing portion, but it's happening sort of across the study, and it's encouraging one outcome over the others in a way that is independent of whatever your intervention is. Okay, because what you're really trying to detect is if you change X, does the incidence of Y change? So if there's something that is biasing the study, it is either moving you towards or away from determining that there's a cause-effect relationship in a way that doesn't have anything to do with the cause or effect. Okay. All right, Dr. McGee. In an outbreak, this measure describes the proportion of new cases occurring over a specified period of time among people at risk. Good. Who knows what it's called when you're talking about it in an outbreak? Good. Yeah, attack rate. So this is one of those fun, like it's not actually a rate, but we call it a rate, but it is the incidence. So new cases in a population at risk over a period of time. But if you hear people say attack rate, it's not a true rate. There's no time component aside from that you specify the time you're talking about, but it really is, it's an incidence. Good. All right, Dr. Amjad, a form of selection bias. Blank bias is introduced when a screening test detects disease earlier without leading to improved outcomes or mortality. Good. Anybody remember what the other one is? That's annoyingly named something very similar. Length time bias. You remember what that is? What does it hurt? Anybody remember? So length time bias is the tendency of a screening test to detect disease preferentially that has a long latent period, or a slow, essentially to detect more indolent and therefore less deadly disease. It makes it appear that the test is improving outcomes, but in reality, so remember, this is one where you look at prostate cancer. So PSAs fall in this category because you tend to detect indolent cancers that weren't really going to kill the person in the first place. And it appears like you're improving outcomes. In reality, you're still missing those really aggressive cancers. All right, so lead time and length time. All right, anybody remember this one?
So not values like the multiplier for the severity and spread of the disease.
Good. Anybody remember what any of the variables go into? I just put a bunch of letters up there. I'm mean like that. All right, so this is the basic reproductive number. I only put this up there because people are actually reporting this now, and you have to know what matters. And it's also conceptually interesting, I think, to think about what goes into spread of disease. So basic reproductive number is this first number. The B stands for the per contract probability of transmission. This is sort of an inherent feature of the actual bug itself. So whether it be a virus, parasite, what have you. And then C is the contact rate. So the number of people you come into contact with. This is where our behavioral interventions can reduce the C. And then D is the infective period. So essentially how long you are infectious from the time your viral load gets high enough to infect another person to the time where you clear the virus. All right, Dr. Emery. This type of study can be prospective or retrospective and selects subjects based on some risk factor, estimates rates of outcome of interest.
This would be a case, not case control, cohort.
Very good. Awesome. All right. So the things that tell you this is a cohort is what it's selected upon and then what you're following for, right? So if you had selected on the outcome and looked at the risk factors, what would that be? Perfect. Good. And so remembering cohort is kind of a big umbrella term. It's a lot of what you see out there. It is technically in the observational category of studies, but it's probably the most experimental observational study. And we're going to recap study types because it matters the type of study as to what measures of association you can even use. Okay. So understanding how to identify what type of study it really is will let you know if they use the correct measure of association. Good. And so cohort studies can be either directional, but the biggest thing is that you're sampling on some sort of exposure, and then your outcome, whether you're looking back to determine whether they developed or whether you're looking forward, is the disease of interest, condition of interest. All right, hard to picture. The extent to which a test measures what it's supposed to measure. You want to help them out? Close. It's part of it. Sensitivity and good. All right, so there's a bigger umbrella term for that, and that's validity. So accuracy is the combination of sensitivity and specificity, but also has to do with the incidence the prevalence of the disease in population. So validity is really the more appropriate umbrella term, and validity essentially means, are you measuring what you're trying to measure? So we talked about internal validity of a study. Did your study measure what you set it out to measure? A lot of times we use surrogate outcome measures. So if you use surrogates that are too far removed from the actual outcome, then it compromises your internal validity. The external validity of a study is how applicable it is to the general population. So how much does what you measured in your study reflect what's happening in the general population? And then the validity of a test measured by sensitivity and specificity is how good is your test at measuring what you want to actually measure? Because very rarely in the world of medicine are we actually measuring the very thing that we are trying to measure, because we use biomarkers and we use constellations of things and we use different reagents and we use different assays. So the validity of the test is how well does the test measure what you want it to measure. All right, one more, Dr. Jalala. It's a lot of words, don't panic. I use nice round numbers. A new test has been used to develop, or has been developed to diagnose primary angle closure glaucoma. I'm just going to say glaucoma. This test has been performed in 1,000 patients who have confirmed disease on the gold standard test, and then 1,000 normal people as controls. The authors found that 900 patients were correctly classified as having glaucoma by the new test. The sensitivity of the new test is, which is, yes. Yes, good. So remember, sensitivity is true positive rate, specificity is true negative rate. So correctly classified, so the true positives is 900 over all the positives, which they took 1,000 patients they knew had this disease. And this is actually how new tests are studied. You take people you know have the disease already by whatever is considered the gold standard, and then you give them and normal controls the test of interest and see what your outcomes are. If it's a stable disease process like glaucoma, a lot of times you'll even test the whole sample like a few different times to determine kind of what the overall sensitivity and specificity are. Good. Excellent. Okay, so we're going to get into sort of new material at this point, and we're going to continue to talk a little bit about hypothesis testing. So you spend all this time designing your study, deciding what is your hypothesis, what's your X, what's your Y, how are you going to operationalize them, how are you going to measure them, what is sort of the background of what's going on, and then you have to figure out what your data ultimately means. So what we're going to move from, as we alluded to earlier, is descriptive statistics. So there's a lot of great epidemiologic studies. There's a lot of great sort of observational things on the ecologic and epidemiologic level that just look at what's out there. How much of this is there? How big of a problem is this? And a lot of times that's a great first step. But typically when you're designing a study, you want to figure out if some intervention made a difference or some risk factor made a difference in the reported incidence or prevalence of the disease. So then you're going to move from sort of observational or descriptive stuff to analytics. You're actually examining the rates, the relative rates of the disease between very specific groups. So analytic statistics allow you to compare the rates of disease between two groups of people. So typically, and this can be expanded, but we're going to talk about it in terms of what y'all will actually see. So typically, you're looking at the difference in disease incidence between an exposed or an unexposed population. Exposure can be a good thing, it can be a bad thing, it can be a drug, it can be an environmental exposure, it can be a prior illness, but some exposure, yes, no, and some outcome, typically a disease, often also mortality, which is technically a real bad disease. So you're using these analytic statistics to answer the question of, is your exposure related to the outcome in your population? So is taking an aspirin related to acute coronary disease in the general population? And to figure this out, you need to compare the incidence of these two in people who take aspirin and people who do not. So to do this, we use measures of association. Have y'all heard that term? I mean, I know you've probably heard all three words, or you probably wouldn't be here, but have you? Okay. So you'll find that you actually do know what this means, whether you've had it like specifically defined. So they fall into two big buckets. There are absolute measures of association, which we're actually going to talk about second because they're not as commonly used, but they have a lot of value. So if absolute measures of association quantify the actual numerical excess risk or rate of disease in exposed over an unexposed group. So this is very commonly used in like sort of the public health realm or on a population level, because you are typically trying to either prove that your intervention reduced the number of diseased people in the population, or that the impact of your disease, what the impact of your intervention could have on the disease in the population. So it gives you sort of a numerical amount of disease that either a risk factor is associated with increasing or a preventative measure is associated with decreasing. So how many fewer or more cases of disease are in an exposed versus an unexposed group? So there's a lot of value in that. However, what you see more commonly, and there's some pitfalls to the fact that we use this more commonly, and realistically, if you had both, you'd have the most information. But relative measures allow you to examine kind of simultaneously the risk in an exposed and an unexposed group. Because in reality, so take our aspirin and coronary disease example, there's a lot more things that go into development of coronary disease than whether or not you take an aspirin. So using a relative measure of association sort of lets you account for some of the risk factors that are present in both groups and try and tease out what's the effect of your intervention. So in this case, the aspirin. Doesn't control for it. And we'll talk about controlling for confounders later, but it lets you sort of examine the risk relative to the other and sort of take into account some of the things that might be present in both groups. It also has value in the sense that the magnitude of whatever this relative measure of association speaks to sort of the strength of your exposure's effect. So things with very large, and this will make more sense when we get into what they actually are, but the magnitude matters in these. So how many times is the risk or rate of disease in the exposed group compared to the unexposed group? Does the difference of these two make sense? So one's looking at amount of difference of disease, and one's looking at rate of development between the two groups. All right. So this is just a recap as well. This will become, we'll recap this for this lecture and then also when we start talking about test statistics. But the measures association you use and the test statistics you use. So when I say test statistics, these are what you more think of conventionally as statistics, when you use a Cox, when you use a t-test, et cetera, et cetera. But it matters on what your variables are. So to do this is where you go back to having good study designs. You need to know what's your X and what's your Y. It sounds really simple when you're doing these middle school examples of what's an experiment, but it can get really complex when you're talking particularly about clinical research. So you need to know what your X is and what type of variable it is, and what your Y is and what your type of variable is. So categorical variables, think of them as putting things in a bucket, defined categories, not necessarily numerical. Numerical variables can be either discrete, meaning there's a finite number of values, usually whole numbers, or continuous, meaning it can take any whole or partial number. So you can see these, I like this, it has pretty good examples here. So most commonly, actually, and sort of on the most simple level, even really complex studies actually employ categorical variables. So typically it is exposed, yes, no, disease, yes, no. So that's your X and your Y. And it's actually very useful for statistical purposes. And hopefully this will come more apparent to y'all as we keep talking about these. But it can be really beneficial when you're designing a study to make as many things categorical, or you'll even see them made what we call dichotomous. So 0 for no, 1 for yes. For things like smoking, yes, no. And you have to think about how you're going to do that. You used to smoke, what category does that person go in? So you have to think about how you're going to do it. But if you can make things sort of dichotomous or categorical, a lot of times it will make it a lot easier to do your statistics on the end. But that was just meant to be a general recap of variables. All right, so we're going to talk about measures of association with a dichotomous exposure, exposed or not, and a dichotomous outcome, disease or not. Okay. Okay. So your whole goal with both relative and absolute measures of association is you want to know how much disease is in the population that was exposed and the population that's not exposed. And we're going to go into a specific example that we'll carry through so we don't have to keep talking about this sort of esoterically. But the 3 relative measures of association are the risk ratio or relative risk, the incidence rate ratio, and the odds ratio. You have all heard of these, yes? Okay, those are the 3. There's another one called a hazard ratio that is a very fancy risk ratio that has to do with logarithmic values of the hazard. So essentially like time over how quickly you die. And you'll see that a lot, but would take a whole lecture to explain. So just know that it's sort of a glorified risk ratio, but more complex than that. But these are the 3 really. So for all of these, they're all centered around 1, like all ratios, right? So a risk or rate ratio of 1 means there's no difference in the group, right? And the closer to 1, the less of a difference it is, right? So if you have a risk ratio, and by convention, it's exposed versus unexposed. So you've got to think about what your intervention is, because a lot of times your intervention or your exposure can actually be a good thing. So you would want something that's less than 1 because that would suggest that it's protective, right? So anything above 1 suggests that there's higher levels of disease in your exposed group. Anything less than 1 suggests that there's lower levels in your exposed group. Does that make sense? Compared to the unexposed group for the period of time of study. Generally, globally makes sense? Okay. So we're going to go into each of the 3 individually. There are some small caveats. You don't have to remember all of this, but hopefully it will sort of get you to where you can at least see these and understand. It's sort of amazing how often they do risk ratios on, and it really wasn't appropriate to do it on, and the conclusions that are drawn may not be correct. So I am going to do the math. Don't worry so much about the math unless it helps you understand it better, but understand how to interpret them is sort of the chief goal. All right, so like all really fun things in statistics, there's a few names for this. So if you see RR, it's referring to this, relative risk or risk ratio. I think relative risk is the most descriptive, so that's what I will probably use. Cumulative incidence ratio is actually probably the most descriptive, but it doesn't fit the RR that is usually used, so I'm going to call it relative risk. But if you see any of these 3 terms, they mean the exact same thing, okay? So I promised an example because I have a hard time with these when they're really like general exposure, general risk. Okay. All right. So this is going to be, I don't know why I'm sticking so much with cards. Just playing to my audience, I guess. So this is an RCT, obviously not blinded. This is actually a real study. Subjects were randomized to either a high fat diet, which is considered the exposure, or they called it regular. It's technically a low fat diet if you look at what the diet actually was, but maybe that's just by current societal standards. So high fat diet is your exposed, low fat diet is your unexposed. And this example is a good illustration of why you've got to keep straight in your head what your exposure is. And also you have to be like very specific about it, what is the outset. So high fat diet is your exposure, low fat diet is your unexposed. And their subjects are followed forward in time, assessed for rates of major adverse cardiac events, which is a great and very commonly used surrogate outcome for essentially like cardiovascular risk. So it encompasses stroke, MI, or death from cardiac causes. But it's dichotomous, right? So you are defining it very specifically, and it encompasses a ton of stuff. But at the end of the day, you're saying, did you eat a lot of fat or not? And did you develop this, yes or no, in the time period, right? So you can see how that outcome measure is very helpful to both define well, understand what it means, figure out, how you're going to deal with people with a history of stroke. Or that, that doesn't count because it was before the intervention, but how are you going to deal with it? How long are you going to follow people up? But at the end of the day, you're ending up with a 2x2 table, right? Which is very handy. So in this case, you've got the people who ate the high fat diet, people who ate the low fat diet, the people who had a major adverse cardiac event, the people who did not. And then you'll notice this other handy column here. Anybody know anything about person years? I'd like to share with us.
So. Following I believe it's the number of years that the following. All 5 years. 5 times the number of people that you follow, that's the person years that you follow them.
No, that was a great stab at it. So what it basically, so has anybody ever been involved in enrolling patients for a study? So if you have, or even if you haven't, you can imagine, you don't have the luxury of walking in and starting your study and having 100 patients that meet your inclusion criteria that start on day 1 timeline. And then you don't have the luxury of following all 100 patients to, 5 years or whatever you're gonna do. What happens more realistically is you start your study and, you have some patients that enroll at different time periods, and then you have some patients who die. You have some patients who develop the outcome of interest. You have some patients who are lost to follow-up. And so what calculating person time does is it actually allows you to account for how much time each person, each participant in your study contributed to the study. And so their clock starts from the time that they're randomized, if it's randomized, or from the time they're enrolled, if it's a cohort study, and their clock stops when they either die or lost to follow-up or develop your outcome of interest, okay? And that's how much person time they contribute to the study, okay? So it's person time because it can be months, it can be years, it can be days, it just depends on what you're studying. I've never seen person minutes, maybe like in fruit flies. But whatever it is you're calculating essentially how much time each individual contributed to the study. And this is really useful because you'll see that this isn't accounted for at all in some measures of association, and it's accounted for very heavily in others. So you can see what different information you get when you account for person time. But this is a very useful thing to use. And in most studies where you're actually enrolling patients, you're going to calculate this. And then it's used sort of variably.
Do they ever report like the breakdown of the 3 options, just says die or I don't know, like
They almost always do. Yeah. So particularly loss to follow-up is a very important one because like we talked about earlier, so per intention to treat, you need to be, you need to be analyzing people as they were randomized. But if you have a very big difference in loss to follow-up between your 2 groups, that has to be reported because you have to account for it. But yeah, it's almost always reported. And the death is almost always reported if that's not your outcome of interest. Sometimes it is your outcome of interest, but those are almost always reported in the method section or in your outcome section. All right, so clinical scenario makes sense. Yes, person time makes sense. Okay, it's super tedious to calculate. It's almost always done in software programs, but just know what it means and know how it's how it means. All right, so we're going to do the 3 in a row. So we're going to start with a risk ratio. So just looking at this before we go into any of these, do you think you're more likely to die if you eat a high fat diet, or you're more likely to have a major cardiac event? Yes. Okay. Is that because you're all doctors? Yes. Okay. So relying on what you know about the mechanism of disease is not a wrong thing to rely on. You just can't rely on it too heavily. But it's important to look at the raw numbers and to compare that with what you know about the mechanism of disease and what you know about what's already out there on the subject to know what you think your data is going to show. Okay. And then you have to prove to yourself that your data actually shows that. And if it doesn't, you need to figure out why. Okay. So eyeballing this, does it look like there's more cardiac disease in the exposed high fat population.
Yes.
Good. So eyeballing it, the disease, the D plus is higher in your E plus group, relatively similar numbers of patients, not huge difference in person time. Okay. So your test statistics or your measures of association should reflect that. Okay. And if it doesn't, you've done the math wrong, or you have a column off in your spreadsheet, or your statistician has pulled the wrong thing. Okay. So knowing what you expect to see, both based on the data in front of you and based on the mechanism of disease, is important. Don't make a square peg fit in a round hole, but if it doesn't, figure out why. All right, so if you're looking at your risk ratio or your relative risk, so as with all of these, you're estimating something in the population. So the probability of disease given that you're exposed divided by the probability of disease given that you're not exposed. So the way you estimate that in your population, or in your sample rather, is you're simply going to divide the diseased by the total number of exposed, right? And then you're going to divide the diseased you're going to divide the disease in the unexposed by the total number of unexposed. So what's the likelihood that you're going to develop this outcome of interest given that you're exposed, divided by the probability that you're going to develop it given that you weren't exposed? All right. So in our population, this is pretty easy. So you're going to divide this 109 divided by 1250, 83, 1245. It's going to give you 1.32. Is that what you expected? Okay, so it's higher than 1. So what does that mean for the relationship? Very good. Very good. Okay, so a big part of this is not just calculating it, not just figuring out if it goes in the direction that you think, but interpreting it, because what you'll see a lot, particularly when these things are published most commonly you'll see it in scientific paper, reported appropriately, and then somebody will pull out just the risk ratio or just the odds ratio. And they'll say, oh my God, if you went to Ecuador in the month that, if you've ever been to Ecuador, you're 10 times more likely to die of dengue fever. And in reality, it was like a very small group of people who were in a very high exposure area that they followed for 4 months, like while they still lived in Ecuador. And so you have to interpret them in the context that they were calculated. So general format for interpreting the risk ratio is that in our study, or over the period of time observed, individuals who are exposed have X times the risk. That's kind of the key phrase of disease, or you can put your specific disease in there, compared to unexposed individuals. Okay. Who have I not picked on yet? Harika, can you do that for our example? Can anybody put our example into this format?
So in our study, over a period of time that we're in our study, individuals who were exposed were 1.32 times the risk of having some kind of adverse disease.
Good.
Compared to
Yeah, this is not, I'm not trying to trick you. Yeah. So in general, you'll put your specific exposure and your specific outcomes. So in our study, we estimate that individuals consuming a high fat diet had 1.3 times the risk of a major adverse cardiac event compared to those in a regular eating a regular low fat diet. Okay. So you want to specify in this statement, what was your exposure and what was your lack of exposure, or if it's 2 different interventions, because sometimes it's 2 different interventions. And you want to specify your outcome. But the phrase is 1.3 times, 2 times the risk. Alternatively, and you'll see this reported a lot as well, the risk of MACE is 32% higher in those consuming a high fat diet compared to those consuming a regular low fat diet. Right. So that's how the risk ratio is often reported. Does that make sense? So it really only applies to the study population. So if you want to apply it to your patient, you need to figure out what the study population was and if it even really applies to you. So that kind of loops back to the external validity of the study, but this is the format for interpreting the risk ratio. So a lot of times the risk ratio is just reported. So you need to make yourself follow the format to figure out what that means to you and what that means sort of for interpreting the outcome of the study. All right, so when can you use the risk ratio or the relative risk? So the big caveats are that everyone must be disease-free at the beginning of the study, and then you have to classify everyone at the end as either having the disease or not having the disease. Ideally, and this is something you can kind of adjust for a little bit on the back end, and you'll see how, but ideally you follow everybody for sort of similar periods of time and have minimal loss to follow up. The similar period of time and loss to follow up is often adjusted for with more complex statistical methods than we're going to get into. But the big thing is, what kind of study can you not use relative risk for? Good. So you cannot use it for case control, right? So you're artificially determining the incidence of disease, right? So you can't use a measure of relative risk of disease because you have artificially determined that, right? So you will actually see studies that try and do this, and they'll come up with some convincing numbers, but they determine the outcome before they did the measure of association. Right. So this is actually really, I didn't make this. I think this is really great though. So for any of your experimental studies, you can use relative risk. And like we talked about earlier, hazard ratio is essentially sort of a glorified relative risk that looks at likelihood of dying with a time component. But relative risk can be used for all of your experimental studies and then your cohort studies. Okay, because remember, you're sampling on the exposure, you're following for the disease. Okay, but remember, you've got to classify everybody at the end. So if you have a study that's sort of done on a rolling basis and you take a snapshot, you can't really account for everybody unless you classify them as disease or not disease. What's up? I thought the same thing when I found it. I was like, I really like this. This is what I needed. It's amazing how often you have to like kind of go back and be like, wait, what is this again? So cohort's the only one you can do from the observational branch of this tree that you can use relative risk for. It's one of the more common ones that you use for, but I like the way this is laid out because cohort really is sort of the most experimental, so to speak, of the observational branch. But none of these you can use relative risk for. You probably wouldn't think about using it for a cross-sectional or an ecologic study, but people will very frequently try and use it for case controls, and that is incorrect. And then, remembering the fact that you have to classify people and similar follow-up are two sort of the sub caveats. Any questions on relative risk? Do you understand that better than when you walked in this room? That's all I ask. All right, the next one, and these are all similar, but this one's probably the most different, I would say, of the three, is the incidence rate ratio. So this one is also sometimes confusingly called the rate ratio, which also is RR, but it should be IRR, and you'll see why. So this one has a time component, which is kind of slick. So we're going to use the exact same example. So high fat diet versus low fat diet, where high fat is your exposure, major adverse cardiac events is your outcome. I didn't change the numbers at all because I'm not that much of a masochist. So this is a true rate. There is a time component. So in order to do this, you are taking into account the person time of follow-up. So the incidence rate ratio compares the incidence rates, meaning people who develop it per their time, in exposed versus unexposed. Okay. So what you're going to do to calculate that is you're going to divide the number of people that are diseased in the exposed group by the total amount of person time that the exposed group contributed. Make sense? And then you are going to divide the number of people who developed the disease in the unexposed group by the total amount of person time that the unexposed group contributed. So you're taking into account the number of diseased people that develop in each group, but you're dividing it by the total amount of time that the people in that group contributed to the study. So you're essentially sort of controlling for the amount of time that each group, and then these are pretty close, but there are times where you're, depending on sort of the latency of your disease process, where the person years contributed are very different between the two groups. And this is really the only relative measure of association that accounts for that. And so it tells you how much greater or lesser the incidence rate of disease in the exposed versus unexposed group. So do you still think that's going to be higher in our exposed group? See a head nod, I'll take it. Okay, so again, very basic format. You're going to divide the number of people who are exposed and diseased by the person time of follow-up in the exposed group, by the number of people who are diseased but unexposed by the person time of follow-up in the unexposed group. So you get 1.4. Expected? Yeah, Okay, so if the effect is there, right, if your X variable really affects the Y variable, you should not have a change in the direction of any of these measures of association. They should all go in the same direction. The magnitude may change, however. So if the effect is real, the person time of follow-up actually probably did make a difference between these two groups because the incidence rate ratio is actually higher than our relative risk, right? So this accounts for the fact that maybe the people in the unexposed group contributed more person time. However, relative to how much disease they contributed, the actual proportion of the incident or the ratio is actually a little bit higher. So to interpret an incidence rate ratio, we also have a little script, which I actually have these on a piece of paper that I have to look back at sometimes. So in our study, or over the period of time observed, individuals who are exposed have X times the incidence rate of disease compared to unexposed individuals. Anybody want to take a stab at this? Who have I not? Dr. Farrell.
In our study over, I don't know what period of time was.
I didn't tell you.
Okay. So in our study over like a period of time, the individuals exposed to a high fat diet have 1.4 times rate of disease compared to
That's right. Good. Right. Excellent. So the incidence rate of MACE is 40% higher in those consuming a high fat diet compared to those consuming a low fat diet. So the biggest thing to remember on this is that there is a time component. It does account for person time of follow-up. It is probably more informative than the relative risk, but is less commonly reported. Make sense? Okay. At the end of the day, it ends up being a unitless ratio. You're dividing something by, essentially something of the same units. So it is still just at its core a ratio, but the magnitude matters. So the higher it is, the greater the magnitude of effect. All right, so caveats to this. So it helps account for the fact that individuals participating in a study often have unequal time of follow-up. So if you remember the relative risk, you really should only use a relative risk if people were followed up for similar amounts of time. So if you have very big differences, you should really be reporting the incidence rate ratio. Because people who are followed for longer contribute more time to the study. They have more time to develop the disease of interest. And if they don't, that is more informative to you, whether or not they're exposed than somebody who you followed for a short period of time and then they move to Tallahassee. I don't have anything against Tallahassee. Okay, so this is actually not on here, but the people that you can apply this to are this type of studies you can apply to are the same as relative risk, but you have to have person time. And realistically, you can apply it in more scenarios because you are accounting for unequal follow-up, which is particularly in true RCTs and experimental studies, you're rarely going to have the same person time and follow-up. Okay, cohort studies you might, because you're sort of artificially controlling those things. You're deciding, hey, I'm looking at people from this time to this time. But in experimental trials and true experimental trials and in prospective cohorts, you're usually going to have unequal person time of follow-up. So you can use the incidence rate ratio for this. Good. All right, last one. Odds ratio. Who understands what an odd is? Any sports fans in the house? Okay. Not that wants to describe what an odd is. I have a hard time describing this, so I'm going to apologize in advance. I don't think I'm going to do a great job of this, but what we've been talking about so far has been a lot of probabilities. So probabilities have a lot to do with sort of the likelihood of an event occurring over all of the possible issues, like all the possible outcomes. The odds is the probability of an event occurring divided by the probability of it not occurring. So those sound really similar, but I like this picture because it sort of visually gives you. So these are 12 marbles. The probability of drawing out a blue marble, we're going to do a single experiment. We're not getting into joint probabilities, but so probability of pulling out a blue marble, there's 3 blue marbles, right? So out of 12 marbles, you have 3 out of 12. So you have a 25% likelihood of pulling out a blue marble. The probability is 1/4, okay? But what are your odds of pulling out a blue marble? So there's still 3 blue marbles. So your numerator is the same for probability and odds, but For odds, you do not account for in the denominator the event. Does that make sense? So the event in this case is drawing a blue marble. So you subtract those 3 from your denominator. So you're doing 3 out of 9. So you have a 1 out of 3 chance of drawing a blue marble. Does that make sense? Okay. So they are related, but they differ. Okay. And so the odds ratio is exactly what it sounds like. Okay. So you can actually convert between the two, assuming that you have sort of all of the information. You can see how that would be the case. But you need to know if you're talking about odds or probability, because you can see that they're actually very different and they give you different information. All right. But you can calculate it for our example, just like you can calculate anything for example. So in this case, you're looking at the odds of disease and exposed. So the math is a little bit more complicated because you have to take out the not probability from the denominator. So before we were just doing probabilities, right? We were comparing the probability of disease and exposed. So disease divided by all of the exposed. But in an odds, you're going to do disease divided by the probability of all those exposed who did not get the disease. So you're putting in the denominator the not diseased but exposed. Does that make sense? Okay. So if you go through all this math, which I'm not going to do, I can send you the slides if you want to do it yourself later. But you end up with 1.31. So you can see that those are pretty similar, right? So you can see how people would use them potentially interchangeably. There are circumstances in which the odds are very similar to the risk ratio or the relative risk. And there are situations in which they are not. But because you take the disease out of the denominator, you can actually use odds ratios in case control studies, because you're essentially taking the disease out of the numerator and the denominator essentially. And it's allowing you to kind of account for the fact that you determined the disease incidence. So to interpret an odds ratio, it's the same format. Oh, I didn't change this. Okay. The individual exposed have like times the odds, is what that should say, of disease compared to exposed individuals. So in our study, we anticipate that individuals consuming a high-fat diet had 1.31 times the odds of a major adverse cardiac event compared to those in a regular diet, or the odds of MACE are 31% higher. So odds ratios are often reported instead of relative risk in cohort studies. This is largely by convention. However, as in our example, odds ratios and relative risk are relatively similar, but only when your outcome of interest is rare. So this is essentially comparing what happens when the prevalence of your disease goes up. So there are times where most things that we study, even when we think they're common, are actually in the general population pretty rare. You think about certain cancers, you think about certain things. Like if you're a breast surgeon, breast cancer is incredibly common. However, if you look at the general population, it's still common, but you run into 100 people, half of them are dudes. And then, of the other 50, maybe 10 of them have breast cancer in their lifetime. So all of a sudden you go down, to less than 10%. So if you look at these sort of prevalence numbers, there's no exact cutoff. But the thing to remember is that your odds ratio can approximate your relative risk when your outcome of interest is rare. The more prevalent the outcome becomes, the less true that holds. And so using odds ratios in cohort studies is fine, but you have to think about what your outcome of interest is. And if it's a disease, you need to make sure that it's sufficiently rare to make that appropriate. And if not, you need to be using relative risk. Okay. So both are valid. You just have to know how to interpret them. Historically, odds ratios were used in cohort studies, but you can do either. So cohort studies, you can use relative risk, assuming that you have the follow-up parameters met, and assuming that everyone is adequately classified as diseased or non-diseased. But if it's not a cohort study, you need to report the odds ratio in addition to whatever else you're reporting. The incidence of disease, when we talked about there is no absolute cutoff, generally 5 or 10% is considered the point at which the odds ratio and the relative risk are pretty close. So it's more for kind of back of the napkin math and for if you see them, how to interpret one or the other. But just know that if you are getting into things that are more prevalent in the population, you really should be using the relative risk, particularly in cohort studies. That makes sense? All right, practice questions today. All right, does anybody have questions about those three? So we did relative risk, incidence rate ratio, and odds ratio. It's March Madness. Y'all should be able to do odds now. Yeah.
What is the benefit of doing odds ratio at a lower incidence of disease or in a rare disease? What's the benefit of doing odds ratio versus relative ratio?
So I think in the general, like for the general, so part of it is just convention. So part of it's like, this is what we calculate because this is what the people before us calculated. I think honestly, it's just people are more used to it, so they kind of know what to make of it. So you think about
Because it's more complicated.
probably you're just trying to be assholes, yeah. Probably. Yeah, I don't know if there's any like real reason why it's better. If it's a case control study, it's because you don't have any other option. If it's a cohort, it's convention. If it's an experimental study, you're probably reporting all of these. Just whichever one's going to make the prettier graphic is what you're going to report in your figures. But realistically, if you truly read the results section of any paper, more than one of these things is going to be reported. You just gotta have to know. And they'll typically choose the most impactful or the most reflective one to put in the abstract and in the conclusions. But if you really read the results, there will be more than one measure of association reported usually. Cool. Other questions? Does that make sense? Kind of, sort of. Okay, cool. Y'all have a good day. So sweaty.